All right, and the last talk before we take a break is addressing perioperative assessment and management. Dr. Ahmed Soliman actually will be joining us just within 2 weeks or 3 weeks as part of our faculty. Great to have him. He's our senior fellow now and certainly has a lot of experience from clinical cardiology and many other areas, and he will address this topic. And Ahmed, let's do it on time so we can have maybe a few questions.
Okay, good morning. So we're going to go over a topic that we all have to deal with in the inpatient setting and the outpatient setting. What we're going to try to do is we're going to try to identify the different types and different levels of surgeries that you're going to manage. How are we going to evaluate these patients? What you should order and what sometimes you should not order. And when is it time to refer to a cardiologist to reevaluate this patient? The 2014 guidelines is the backbone of what we use in regards to the information and how we evaluate these patients before undergoing non-cardiac surgery. So a couple of terminology, for terminology's sake. What is an emergency procedure? What's an urgent procedure? What emergency procedures are life-threatening procedures if that patient does not undergo the procedure within the next 6 hours. An urgent procedure is within the day. And time-sensitive is relatively, the first two you would see as an inpatient for the most part. The second two, time-sensitive or electives, are usually your outpatient referrals for evaluation for perioperative cardiovascular risk assessment. What you're trying to do, and what you're trying to do with this pre-op evaluation, is to assess the risk or the cardiovascular risk to guide the surgeon or the surgery team or the anesthesiologist in regards to management. If you need to change anything in their management prior to surgery. And identifying the possible complications that may occur, including myocardial infarctions, heart failure, volume overload, or decompensation of already established heart failure, different types of arrhythmias, or in regards to atrial fibrillation or VT or so forth. I think one of the most important aspects of this is that we all should do this as a team, because it's important that a cardiovascular patient, especially that has established cardiovascular disease, that primary care physicians or other physicians that are managing these patients as an outpatient have an open communication with their cardiologists or cardiovascular surgeons. So this is a simplified algorithm, if you may. It's also available in the guidelines, but it'll explain to you, if you take a look on the top, it'll tell you if the patient has needs to undergo an emergency surgery, then you're going to do as much as you can do for clinical risk, but then that patient still needs to obviously go to surgery. But then it breaks it down into steps, and we're going to go over these steps momentarily. The Revised Cardiovascular Risk Index, or the RCRI, is our go-to risk calculator. There are a couple other risk calculators that we use out there on a regular basis, but this is for the most part what we use. And it is a score in which you give 1 point to each one of the following. The type of procedure that the patient is going to undergo. Is it an intermediate high-risk procedures? And these are usually vascular surgery procedures, except for carotid we'll go over, or intraperitoneal intrathoracic surgeries. Ischemic heart disease. And when we say ischemic heart disease, does not necessarily, the patient can have a previous MI in the past and not have been revascularized, did not have a stent or did not have bypass surgery or so forth, or obviously a positive stress test, that's automatically ischemic heart disease. The patient is in clinical heart failure, so he does not necessarily have to have a low EF, i.e. he has an S3, he has RALS, he has pulmonary edema on his chest x-ray or on his exam, a previous history of a TIA or a previous history of a stroke. That counts as a point. Insulin-treated diabetes and renal dysfunction. Again, the risk goes up, or the risk increases as the as the seriousness of the procedure occurs. But for the most part, any vascular surgery that patient is going to undergo, except for carotid, is high-risk procedure. We'll go over a few of the patients that you will probably interact with, patients that already have coronary artery disease. If that patient had a previous MI, the general consensus is you want that patient to be far away from that incident MI as far as possible. The more the time pass, the better. We have data to show that at least 60 days, but we also know that even if you've had an MI within the last 6 months, you still have a little bit of a higher risk. So if a patient has had an MI in the past, if it's an elective procedure, you want to delay that procedure as much as possible. In regards to medications for these patients that have coronary disease, if the patient is already on a statin, he continues on a statin. There's no change in that regards. There has been some evidence, these are 2A and 2B indications, to use a statin on patients that undergo vascular surgery, as you've heard before during the last talk, that there is an anti-inflammatory effect with the use of statins. So there is some indication to use that on patients that are undergoing vascular surgeries. Now, the question regarding beta blocker is always a question that we get asked all the time. As you see, the only class 1 indication for beta blocker management perioperatively is a patient that's already been on a beta blocker. We always get asked about, do we start a beta blocker now if the patient's going to go to surgery tomorrow or the day after? If you have a higher risk on the calculator in regards to cardiovascular risk, perioperative cardiovascular risk, it is reasonable to start a beta blocker. But the point of that would be that if you're starting it, you should start it well in advance of any procedure. Meaning, if you're going to start it a week, the recommendation is a week. I personally, if you have the time, I would rather 2 weeks or so. And the point is that you want to see what the patient how the patient is going to tolerate the beta blocker, and if he's able to, and if he has any signs or symptoms that occur because of the beta blocker he's going to receive. But again, for the most part, it is the only high recommendation or the only class 1 recommendation is if a patient is already on a beta blocker. The other question that we always get asked is regarding antiplatelet therapy. And there has been a shift a little bit in regards to the newer generation stents that we have available to us right now. And what I'm going to show you momentarily is that is the timing of elective procedures after PCI. So a simple angioplasty, you want to wait at least 14 days. If a patient receives a bare metal stent, and we're talking about the dual antiplatelet therapy, we're talking about the aspirin Plavix or aspirin Brilinta or aspirin and Effient, we're talking about the question that you would get asked, when can I stop the Plavix? When can I stop the Effient? Or when can I start the second part of the dual antiplatelet therapy? So it's 30 days after a bare metal stent. It is between 6 months to a year in regards to drug-eluting stents. But the trick on this is, frankly, and I tell patients in clinic all the time, if you got a stent by a cardiologist, you go back to that cardiologist before you stop the dual antiplatelet therapy. This has to be in, again, communication with your colleagues in regards to the timing of when do you stop the second antiplatelet therapy. Patients that have heart failure. So heart failure, we know, obviously, I'm sure that everybody's encountered heart failure patients. They do have a higher perioperative risk. They have a higher risk, actually, than coronary disease patients. But that being said, patients that have stable disease, meaning they are on the appropriate therapy, the functional class, the New York Heart Association class is 1 or 2. On examination, they don't have S3s, they don't have RALs, they're doing reasonably well, they're stable patients. For the most part, they can undergo surgery. The only problem with them sometimes is because during surgery, they receive volumes, they receive different types of anesthetic medications. They may require a little bit longer hospitalization, and they have a higher risk of readmissions. So the better you optimize these patients before surgery, meaning their blood pressure, their volume, and making sure that they are on the appropriate heart failure medications, the better the outcomes. Systolic heart failure, and forgive me, we'll take a step back. And when we talk about the last set of patients, we're talking about clinical heart failure, meaning even if they have diastolic heart failure, if they're volume overloaded and they're tachycardic and they are short of breath, that's obviously a high risk. So the EF number is a factor, but clinically, that's also a major factor. So EF in of itself is an independent risk factor. So if you think about it, the risk order for heart failure patients is a symptomatic systolic heart failure patient, an asymptomatic LV systolic heart failure patient, and an asymptomatic diastolic heart failure patient in regards to the order of risk. There has been some information regarding getting a BNP prior to these procedures as a predictor for postoperative problems. In regards to valve disease patients, if you have a patient that you're seeing for the first time and you hear a murmur or you suspect a valve disorder, get an echocardiogram to evaluate the valve disorder. But if you already have a patient that you've been following, or that patient is already telling you that I already have an element of mitral regurgitation or aortic regurgitation or aortic stenosis, if that patient had an echocardiogram within the last year and he's doing well with his symptoms have not changed, you do not necessarily need an echocardiogram if his clinical symptoms are just about the same and you've had an evaluation of that valve. If you have not had an evaluation in the last 6 months, 1 year, or that patient will tell you my symptoms are getting worse in regards to heart failure symptoms or chest pain or so forth, then that requires another evaluation. But the general rule for valve disease, for valve patients, that for moderate or severe disease, we don't necessarily intervene on a valve because the patient is going to go undergo surgery. We intervene on a valve if that patient requires intervention on that valve regardless. Meaning if that patient has severe aortic valve stenosis and he is symptomatic, we do need to change that aortic valve. But if he has moderate aortic stenosis and he's undergoing inguinal hernia repair or so forth, that does not mean that we need to undergo any intervention on the valve if he's asymptomatic. The other point of this is, especially in mitral stenosis patients, aortic stenosis patients, or frankly all valve patients, if they have moderate severe disease, and they're about to undergo surgery, you want them to undergo surgery in a hospital system that can manage, that have cardiovascular anesthesiologists and have a valve expertise, because these patients have a very, or can easily decompensate with volume changes and with anesthetic medications. Again, on a case-by-case basis, occasionally we can do an aortic valvuloplasty for a transient period of time preoperatively, but this is again on a case-by-case basis. Again, sometimes mitral valve commissurotomy for mitral stenosis patients, for example, that are currently pregnant. So these are all case-by-case basis, and again, goes back to a valve center with the expertise for this. A quick point regarding infective endocarditis, you're going to be asked that question sometimes for prophylaxis about these patients. So any mechanical valve or any prosthetic material that the patient has, meaning if that patient had a ring inserted for a mitral valve or has artificial chordae. Adult congenital disease, frankly, if you already have an adult congenital disease patient, I would refer to, like Eunice had said, to one of the adult congenital heart disease centers. Any dental procedure that manipulates the gingiva, meaning if you're doing a normal cleaning, that should not require it. But if you're doing some sort of extraction or anything that would break the barrier, that would require antibiotic therapy. And for the most part, the general consensus is amoxicillin or ampicillin within an hour of the procedure itself. And you could use rocephin and clindamycin, clarithromycin down on the hierarchy, if you may. In regards to arrhythmias, patients that have PVCs or non-sustained VTs, occasionally that are not symptomatic and they have a normal LV function, you don't need to do anything about those. Patients that have atrial fibrillation, if their heart rate reasonably controlled, they're fine. We usually consensus the heart rate under 100 or 100 or 90. That should not require any further evaluation. And again, patients that have a previous sinus nodal disease or AV blocks would need further evaluation. Another question is, a patient that's on antiplatelet therapy or anticoagulation, how long before the surgery do I need to stop these medications? So the new oral anticoagulant medications, the apixaban, rivaroxaban, and so forth, the consensus is usually about 2 days. Aspirin, up to about a week. Plavix and Brilinta, 5 days. And Effient, about 7 days. Another question would be, do we need to check any biomarkers to evaluate for preoperative risk? You would think that BNP and CRP would be probably the go-to biomarkers. And there's some data on it, but it's not sufficient data to give us a routine use to evaluate for postoperative risk. Simple stuff, EKG. Why not? Well, if you have a low surgery risk on a low surgery a simple surgery with a low surgical risk patient, you don't even need to do an EKG. We automatically do EKGs all the time. What's the harm in that? But if you have a patient that has a previous cardiovascular disease, coronary disease, arrhythmias, heart failure, and so forth, should obtain an EKG. And it could always be of help as a baseline EKG for post-operative changes in his EKG. Assessment of LV function, this is something that we get all the time. We get echocardiograms all the time to evaluate preoperatively. When do you get an echocardiogram? You get an echocardiogram if that patient has symptoms of heart failure or symptoms that are unknown origin that you don't have an explanation for prior to this. Patients that have change in their clinical status. They already established heart failure, but their symptoms are getting worse. Or they have established heart failure, and again, they have not been assessed within the last year, very similar to our valve concept. But you do not need an echocardiogram just because a 40-year-old is going to undergo an inguinal hernia repair or a simple surgery. Functional status, I think, is something that is undermined or evaluated significantly. We use our metabolic equivalence for an estimate. So the way I look at it personally is that the extremes, the top extreme, the patient that is sedentary and not really active, and the low extreme, or on the lower part of the page, I mean, the person that has excellent METs. So he tells you, I bike 100 miles a week, and I run the race track 3 times a week. He's fine. His METs are, his functional status is excellent. And then the other person that tells you, I really don't do much, I sometimes just go to the fridge and get something from the fridge. Those are the extremes. The problem is, I think, is in the middle, that gray zone. If you ask a person, are you able to go up the stairs? You say, oh yeah, I can go up the stairs. But the way I go up the stairs running versus you going up the stairs taking 2 minutes is different. So, you can ask these questions, but like Dr. Pratt used to tell us, you have to trust, but you have to verify. And we'll get to that. So a person that has more than 10 METs, or i.e. the excellent functional status, you do not need to do any further testing. The patient that has in that gray zone, on the guidelines, you can forego any further testing. But again, trust but verify. If you could verify that that patient is really as functional as he describes, fine. If you cannot verify and he sounds like he's kind of, then you need to go to the step and verify his functional status. And then obviously if unknown functional status or a patient that comes in, 89-year-old patient that has a now hip fracture, you cannot verify obviously and their functional status is not clear. But you do not need to do a stress test on any patient. Go ahead.
Voila.
Okay. All right.
No, I think you covered a lot. I'm mindful of your break. I think you're going to have all this information. I think what we've done is with the knowledge that we had a medical urgency that we had to take care of it. Why don't we have a break for about 15, 20 minutes. You know, go to our exhibitors, have a bite, and then we'll see each other back. Thank you again.